Esteemed members, good evening, and thank you for joining us today. As we start, I'd just like to confirm if you can hear me and send a message on the chat. Let us know which PSK branch you're joining us from. Good evening, Dr. Hillary. Thanks for joining. All right, thank you. I see you can hear me. Good evening, all. Thank you. See Dr. Dennis from Lower Eastern. Welcome. Dr. Shah from Nairobi, welcome. Dr. Kodio from Nairobi branch, Karibu. Kindly indicate the branch you're coming from. Good evening, Dr. Sheila Mary. Dr. Shital from North Rift, welcome. Dr. Eric from South Nyanza, welcome. Dr. David from Embu, Dr. Paul from Kitale, Karibuni. Dr. Clinton from Coast, welcome. Dr. Zachary from Bungoma, Karibu, Karibu. So meanwhile, as we wait for more of our colleagues to join, I'd like to just urge you to all go to your PPB portal and subscribe to the events. Just take a few minutes of your time, go to the PPB portal and search for the keyword FP, and you should be able to find the event easily. The event name is Dissemination of FP Guidelines, Session 1. This is going to be a series of 3 webinars, so kindly be on the lookout for the following sessions that we'll be having. For those who've just joined us, we're subscribing to this event on the PPB portal. So kindly go to the PPB portal and search for the keyword FP, and you should be able to find this event. And remember, it's a good practice to ensure that you subscribe to this event early on the portal, because that determines how fast we will be able to send you the tokens for the event. So the earlier you subscribe, the earlier you get the tokens for the event. So I think we will start now. We have a good number. And once again, welcome for joining us today. The webinar today is on dissemination of family planning guidelines. And this is part of the OPC project that is being run by Pharmaceutical Society of Kenya in partnership with the In Supply. And for this session, we have Dr. Isaac Malonza, who is the CEO and Technical Director for URADCA, which is also one of the key partners for the OPC project. So he's going to be speaking on the key issues that you need to understand about the guidelines, and we'll also be having 2 other sessions where he'll also be coming on board. So once again, subscribe on the PPB portal, use the keyword FP, and you'll be able to find the event easily. Just a few ground rules for this session. You'll be muted. So if you have any questions, kindly utilize the Q&A tab and not the chat. That way, we'll be able to track your questions easily and they'll be addressed. This session is being recorded and it will be made on the PSK's YouTube page. So for the session today, we'll just have Dr. Isaac will be speaking. on the main topic, and then later on we'll have a representative from InSupply and the technical project lead for the project will also be saying something about the project. So at this point, I'd like to welcome Dr. Isaac to come in. Dr. Isaac, if you can hear me.
Yes, Hezron, I can hear you. Good evening.
Good evening. Karibu Daktari.
So do you want me to introduce myself and start my presentation now?
Yeah. Yes, please. That's okay.
Okay. I believe you can see my presentation
Yes.
on the screen. Let me put my camera and see if people can see me so they know who is talking. I'm unable to see my face, but I don't know whether you guys can see.
Let me just check if there's an issue, but I think it should be okay. And sorry, Doctor, I just wanted to send a reminder to the members that we have a pre-test poll that will be going online, so you can participate as you listen, and then later on we'll be having a post-test just to get to know if you've been able to understand today's session. I'm still unable to see you. I don't know if it's an issue with the camera on your end.
Maybe, but anyway, it's okay.
Yeah.
It's dark. It's just dark. I don't know. Okay, I'll work on the camera later. But now maybe you can see the face projected.
Yes.
Okay. Okay, so it's I'm very excited to have the opportunity to partner with PSK and your members for this session. It's a privilege to be asked to facilitate this discussion. As you said, there is a program that InSupply is leading, InSupply Health. It's leading on optimizing the pharmacy channel, basically strengthening the services that can be offered through the pharmacy channel, specifically family planning, reproductive health services. And Uradica, where I come from, we are a partner of that program, so we are very excited to be part of that program. So this program, see if I can move then. Yeah, okay, it can move. Yeah, so maybe others might speak more, provide more details about the OPC program, optimizing the pharmacy channel. But we have 4 primary objectives or outcomes in this program, which is first to strengthen the pharmacy channel by ensuring that they can provide quality FP services, and more importantly, an expanded method choice that can be provided. We are also generating evidence on feasibility and acceptability of being able to introduce and provide implants through the channel, and that's where Uradica comes in. We are going to be undertaking this feasibility and acceptability study as soon as we are approved by the Ministry of Health. And then we jointly work on strengthening the current policy environment, especially the one that will allow the pharmacy channel to provide an expanded method choice. So we are working on that. And part of what we are doing today is we cannot strengthen what we don't know. So part of what we are doing is reaching out to PSK members, being able to disseminate the current policies that are there so that you understand them. And then together we can work on any potential gaps that we identify to ensure that we can provide a strengthened environment for us to work. But more importantly, where the rubber hits the road is to track how many women and girls are actually accessing these services, especially through the pharmacies. So we'll be working together jointly on this over the next few years. So a bit about Uradica. Uradica is a Kenyan NGO. We were registered 29 years ago. We envision a world where people do not die of diseases we can prevent, as well as lifestyle conditions that can be prevented. And our mission is really to improve health and the well-being of Africa peoples. We are here in Kenya, but we also work across other African countries. So why do we disseminate policies? So I thought it's very important for us to know why do we do policy dissemination. One is to ensure that the policy is well understood, it can get implemented, and that whatever the policy is providing can then be followed effectively. So mainly the idea of policy dissemination is to create awareness in our sector, make sure people understand what the policy provides, and then ensure that the policy can be implemented consistently. People can comply with the policy, because if we don't comply, then sometimes there are issues that arise from the regulators, Ministry of Health, Pharmacy and Poison Board. Also being transparent about what the field and the sector can offer. It's a way of empowering our members to be able to know what they are allowed to do and what they are not allowed to do. And so that whatever they are allowed to do, then they can do it without fear of any untoward effects. And also, as we do that, as we disseminate policies, is an opportunity for us to identify areas where we can improve on the policy. We get feedback from users like yourselves, and also we can use it for training and support. So these are all reasons why we disseminate policies. But more importantly, the reason why we have policies is to be able to use them to improve public health and to achieve public health impact. So if the policy is not contributing to public health impact, then it means it's not achieving its intended goal. But we cannot achieve public health impact unless the policy is understood and implemented at scale, not just by some people in some places, but we can only achieve public health impact if we are able to implement the policy across the board, across Kenya, and optimize on what the policy can provide. So in our policy, one of the things that it has done, and maybe before I can, it has done is to give a snapshot of where we are with family planning situation in Kenya. So because the policy we are talking about was developed and approved in 2018, what I'm going to do is to give you the family planning situation data as it stands as of 2022, when the last Kenyan Demographic and Health Survey was conducted. So the modern contraceptive preference rate has increased from 39% in the year 2008-2009, when the previous KDHS was done, to 57 in 2022, when the last KDHS was done. Most commonly used methods that were found was injectables at 20%, implants at 19%, and contraceptive pills at 8%, in that order. The increase in modern contraceptive rate has actually been driven mainly by increases in the use of injectables as well as implants. And as you'll realize, the guideline that we are talking about, the 2018 family planning guideline, actually brought about, expanded the provision of injectables in our sector. And that's why we believe that this is one of the reasons which has contributed to increased MCPR. However, when you look at the national average of 57%, it masks some other counties where they may not be doing as well as we think. So when you look at the MCPR in Mandera, is still very low at 2%, followed by Wajir at 3%. And by the way, CPR is the average number of women of reproductive age who are using a modern contraceptive method. So that percentage of those women in that age during surveys. So when you contrast that with counties like Empu, where the MCPR is already at 82, or in Kirinyaga, where it is over 70%, so you can see that there are counties mainly in the central part of Kenya that are contributing to this high average of 57, whereas we have counties in the northern part of Kenya, which are actually contributing to reducing our national average. So it means there is work for us to do, especially in those counties where the MCPR is below the national average, so that we can be able to achieve the current targets for 2030, where the ministry has committed to a 64 and MCPR of 64 at the national level. So to do that, we will have to improve MCPR in some of these other counties. The figure on the left side kind of summarizes the current use of modern methods as well as traditional methods, which has been kind of stayed constant around 6%. But also it shows you the unmet need of family planning at 14% as of 2022. Unmet need means these are women of reproductive age who would like to use a method, but actually they are not using a method either because of access or other challenges. So moving on, so this is how the guideline looks like, the National Family Planning Guideline for Service Providers, the 6th edition, approved and released for use in 2018. And I need to hasten to say that the ministry is actually working on a new guideline, which should be released this year, hopefully. It's already ready, it's waiting for signature by the senior leadership of the Ministry of Health. And I felt that this was a good time for all of us to share this guideline, which will soon be replaced by the new guideline. So after today, we'll be tracking to see when the new guideline is released, and maybe in partnership with PSK, we can organize another session where we'll update you on what changes will have been made in the new guideline. But for those of us who have worked in family planning for many years, I still consider this guideline to have been one of the most innovative guidelines that we had. He expanded the space for where family planning and reproductive health services can be offered, and specifically who can offer those, and brought clarity in terms of who is allowed to offer what where. And we shall see that as we move along. So some of the key highlights of this guideline is that it identified family planning as a rights issue, and it underscores its role in both economic and social development. Kenya has committed to a number of global goals, including sustainable development goals. And FP is one of those services that can ensure Kenyans access, their rights can be met. The National Family Planning Program at the Ministry of Health, its mandate is really to provide the policy. So their work is to develop policies, to disseminate the policies. So we are assisting them in this regard as partners of the Ministry of Health, and also to provide technical assistance to counties and to partners in implementing the guideline. And also to provide capacity building as part of technical assistance. And also to ensure that family planning standards are implemented. So there is another document that the ministry has called family planning standards in clinical settings. And maybe at some other point, then we will be able to discuss what those standards are, so that as you practice in your pharmacies, then you can know what are the standards that you are supposed to achieve in your work. But that will be a different dissemination. So who can use this guideline? When guidelines are developed, they have to be targeted to who should use it. So the first bullet there is very important. All service providers who are offering or providing family planning services within Kenya, this guideline is theirs. And then, of course, policymakers at county level, at national level, and also for partners who are supporting family planning services and family planning program in Kenya. The guideline offers guidance in the provision of modern methods, mainly modern methods. It focuses on modern family planning methods, to respond to local needs that have been identified in expanding family planning choice, as well as expanding the services to all areas of Kenya. The sixth edition places some emphasis on a few things, and on the right side of the slide, on improving access, because what was found previously is that we still had segments of our population who had challenges accessing the services, either because where the services are being offered are far, or where those services are being offered have other challenges. We also identified some medical barriers that would limit access. There are also, the guideline also addresses how we can reduce missed opportunities, because once we reduce missed opportunities, that's one of ways in which we can reduce unmet need for family planning. Women who want family planning should be able to access it. So when you find 14% of them are not accessing, then that's something that we need to address as a country. Also, we need to increase the number of new users who are enrolled of modern methods. And that's one of the other emphasis that the guideline brought. But more importantly was to frame family planning as a human rights issue, and also to anchor it to our constitution, because in our constitution, reproductive health right is one of the rights that is guaranteed there. So those are key highlights in this sixth edition that I just wanted to highlight. But specifically, what does the guideline address? Just for you to know, it updated the medical eligibility criteria. I'll provide more details about the MEC. It's called MEC. The World Health Organization develops this medical eligibility criteria to clarify who can use which method, and especially people who have certain medical conditions, certain diseases. There is always a challenge as to whether they can use some of the methods safely. And the medical eligibility criteria is an attempt to provide that clarity so that we can reduce on some of the medical barriers, and I will come to that. It spells out task sharing, and there's another guideline that will disseminate to you about task sharing, where the providers say, if you are working in a facility, in a health facility, you have pharmacies, you have pharmaceutical technologies, you have nurses, you have clinical officers, you have medical officers. This guideline attempts to provide clarity on what all these cadres can do to share the tasks for family planning, and I will highlight that as we move along. And also, it tries to articulate some new strategies to reduce access to family planning. One of them is on expanding community-based family planning services, especially through community health promoters or community health volunteers, as we call them. Making sure that women in the postpartum stage are being reached, especially those who deliver in health facilities. By the time they are discharged after delivery, they should be able to go home with a method of their choice if they want. That was one of the missed opportunities that we were having, where women would come deliver in health facilities, and then methods that they can use in the postpartum period, they are not cancelled on them. The other issue is on comprehensive post-abortion care services. That includes family planning, because sometimes we focus on post-abortion care, but then we forget the reason why we are having post-abortion care is because there was an intended pregnancy before that could be prevented with family planning. And then there are special groups that need to be addressed, people living with disabilities, mobile populations, adolescents and youth are special groups that the guideline also attempted to address so that we can reduce missed opportunities. And then more importantly, also in Kenya, we have been rolling out some large parallel programs like the HIV program, malaria program, and others. And these are opportunities where we can be able to also integrate family planning, reproductive health in these services. So the guideline also made an attempt to provide clarity on how we can optimize on integrating family planning in these other services. And then more importantly also is it addresses some of the new contraceptive methods that were available, that had become available in 2018. So I would like to believe that in the new guideline, they will also highlight some new methods that have just become available in the last few years that we would need to be aware of and to provide. I see Japheth has a question. Maybe I don't know whether you'd like to wait for me to finish so that I can manage my time appropriately. Japheth, is that okay? Okay.
Yeah, I think it's
So
okay,
this is
Daktari.
the,
We'll handle the questions.
yeah. So maybe Japheth, you can text on the chat and then my colleagues will help you as I go through the presentation. This is the way the guideline is organized. This is the table of contents from the guideline. It has a forward from a senior Ministry of Health person. We have acknowledgements for the people who helped to contribute to the development of the guideline, a list of abbreviations, which is typical of any document. Chapter 1 is an introduction to the 6th edition. Chapter 2 is provides a background to where we are as Kenya in family planning, and also some of the international goals that we have signed up to as a country. Chapter 3 is on service delivery specific guidelines. Chapter 4 is on client assessment for family planning. And then the other chapters after that, they deal with several different modern methods. So chapter 5 deals with the hormonal contraceptive methods. Chapter 6, intrauterine devices. Chapter 7 is on voluntary surgical contraception. Barrier methods are tackled under chapter 8. And LAM, famous LAM, lactational amenorrhea method on chapter 9. And fertility awareness-based methods on chapter 10. And then there's a chapter 11 that is handling monitoring evaluation of the of the program, as well as family planning commodity management issues. So this is how the guideline is laid out. And after this session, PSK would be happy to share this guideline online if you are not able to access it, but usually it's easy to access it if you just type Kenya National FP Guidelines. It's likely to pop up on your browsers, so you can download it, but we are happy to share. This is one of the tables that is provided in the guideline. It's on page 27. It's a very famous table that I like. If you must forget anything during this presentation, this is what you should not forget. It is table 3.1, provision of FP methods by different categories of service providers. And pharmacies and pharmaceutical technologies are listed on the last row there, as you can see. And then on top, the table summarizes the various family planning methods. So we have male condoms, and the pharmacies are allowed to cancel and provide those. Female condoms, you can cancel and provide. Lactational amenorrhea method, you can cancel and refer. Pills, you can cancel and provide, as you have always been doing in your pharmacies. Injectable contraceptives, you can cancel, you can dispense, and then you can provide with an hysterics if you have already been trained and certified. So there is already a training package by the Ministry of Health where pharmacists and farm techs can be trained to provide injectable contraceptives, especially DMPA-SC, as well as DMPIM. And then those who have been trained then can be able to provide. But you have to be trained and certified by the ministry. Then IUCD, this is intrauterine contraceptive devices. You can cancel, you can dispense, but then you cannot insert. You are supposed to refer for insertion. So you can see if you are working in a facility with other providers, you can actually cancel, dispense, And then you can refer for insertion by your colleagues. And I know there are some chemists or pharmacists who actually have hired some nurses. And this, some of the, in those pharmacies where you have nurses, this actually works well, where insertions can still be provided in the pharmacy because you already have a nurse who is already trained to do so. So you can actually task share those roles with your colleagues. For contraceptive implants, again, you can cancel, you can dispense, but for insertions, you have to refer. For now, there is no curriculum for training pharmacists on insertion of implants because it's not yet allowed in our current policy. As OPC program, we are working with the Ministry of Health to do the feasibility and acceptability study to demonstrate if implants can be safely provided through the pharmacy channel. And in fact, next week, we are undertaking a learning visit to Nigeria where this is being done. And we'll be there with the Ministry of Health, reproductive health colleagues and partners to learn from Nigeria. Then we can come here and see what we can do for Kenya. So stay tuned. After next week, when we come back, the ministry may provide further guidance on how we as OPC may want to conduct those demonstration studies for provision of implants in the pharmacy channel. If this happens, then OPC will be working with the ministry to make sure that this gets into a new policy. Once the demonstration studies are successful and we can show that you people in the pharmacy channel are willing to be trained and you are willing to provide this service safely, but more importantly, that women are actually willing to come to receive those services in your chemists or pharmacies, then Bingo will be able to work on that new policy and extend and expand the services that you can provide. So anyway, so the idea here is to alert you when you have this guideline to go to page 27, use this chart to empower yourself so that whenever you are providing family planning services, you can say that this is what you are authorized to do, and therefore you can work within the policy and expand the implementation of the policy. A few words about the WHO medical eligibility criteria. So this criteria is very important to guide providers on which methods are appropriate for which types of women, and especially women and girls who may have certain medical conditions. So the MEC has certain categories. So category 1 is a situation where the method can be provided safely to anyone, and therefore there are no restrictions. If it is in the MEC, it lists something as category 2, it means you can use it, but with a lot of caution. So you will need to track and maybe frequently follow the person who is using the method. Category 3, the benefits of using the methods the disadvantages of using the method outweigh any benefit. So category 3 is not advisable to use. And the 4 is conditions where it's totally unacceptable to use the method because the health risk is more than the benefit that we can get from using the contraceptive. So 3 and 4 is a no-go zone. 1 and 2 is it's allowed. So the purpose of the MEC is to gives you guidelines on what you can provide. It's also good to address misconceptions about who can use and who cannot use certain methods. And as I have said, it reduces the barriers and they can improve. So this is how it looks like. This is the 2015. There's supposed to be a 2022 one. You can actually download the WHO MEC wheel from your Android Play Store or from those of you who are using iPhones. You can also download it. And then it's very good because it can also quickly train you on the various methods. So it has sections there. I actually have it on my phone as one of my apps that I like. When you download it, it is called contraceptive use tool, and it it summarizes all the modern methods, how to use them, and then you can use it quickly to identify whether there is any contraindication for providing a certain method to someone. For example, from the screen, you can see copper IUD is written as one for postpartum women within the 48 hours. So you can actually insert as soon as a woman has delivered a copper IUD. Usually the cervix is open, so you don't need much equipment. You can actually put it with your hands as we have done before. Yeah, so that's number one, you can use it, but you can see for combined hormonal contraceptives that will not be allowed within the first 48 hours postpartum because it would interfere with breastfeeding. So that would be number four. So this will quickly, if you have it, the will, you can be able to quickly make sure that you are well guided on who can use which method safely. So please download it on your Android phones or iPhones and use to empower yourselves. The other thing that the 2018 guideline did was to address some of the new methods. They were new then, they are not new anymore. One of them was the subcutaneous DMPA-AC, which has been introduced and which you as pharmacists are allowed to provide once you are being trained. And I know that InSupply has been working with PSK to disseminate and train many of you. There was also a new emergency contraception method called Presto acetate UPA, which I'm sure you know and maybe you are selling in your pharmacies. And then the vaginal rings that are becoming common. Some of the vaginal rings prevent HIV as well as prevent pregnancy. So they are dual methods. So these are new methods that were captured in 2018. So when we have the new 2025 version, it will capture some new methods that will have been developed between 2018 and now. One of the other issues that it captures is the issue of data flow. The Ministry of Health uses the DHIS2 as our main health facility data capture for family planning as well as for other methods. And I know now that there is an online data reporting system that pharmacists and farm temps can log on to as long as your facility is has the SDP number. Then you can be able to get permission to log on and report on utilization of your commodities. So data and data use is very important. And this is one of the challenges that the ministry has resisted, or at least had challenges with the pharmacy channel, saying that we are providing commodities to the pharmacy channel, but they are hesitant to report. And we've been trying to work with your teams to know what are the challenges of reporting. Of course, one of them has been getting the tools to report. Many of them used to be hard copy tools, which are not easy to access. But now we have an online system that some of you are already using. So that makes it easy. You only need to have the login credentials for your facility, and then you can be able to report. So if we can be able to report, I think that would also empower the family planning program in decision making and policy making. Because when we don't report, then they don't have comprehensive data on what is going on with the services that we are providing. And the guideline actually goes ahead to try and emphasize why quality data is needed. So reporting is just one issue, but whether we are reporting quality data and in a timely manner is very important. So issues of timeliness, accuracy, reliability of the data, precision, is very important. And also ensuring confidentiality of the data that we are reporting. So I think the emphasis we are making is through PSK. Those of you may not be aware and you are providing FP services, please be linked to the online reporting system so that we can be able to advance that aspect of our work. The other highlight from the guideline is some special highlights that were mentioned. Some of them I mentioned earlier. Community-based family planning need to be expanded. That famous table table 3.1 on page 27, the one that I showed earlier, it actually shows the methods that community health promoters can provide and what tasks they can help in expanding community-based FP. Male engagement has been flagged as an issue where women seems to have more information because they tend to frequent clinics for reproductive health purposes, but we are not reaching men, and yet we need men to be engaged, especially with their spouses and partners. And then the other issue is the quality of family planning counseling has been an issue. And there is already several methods for how we can be able to be trained and empowered to train to properly, adequately counsel women so that they can make an informed choice. So counseling has been another missing link in ensuring that women are making the right choices based on the information that they have. Infection prevention and control is important, especially for those invasive FP procedures that require us to have infection control. Discontinuation is also another topic that has been addressed. We will need to reduce discontinuation where it is unnecessary. Obviously, where we need women to switch because their needs and requirements are changed, then again, that's emphasized. MEC, I have said, and I have also mentioned about the vaginal ring. So these were key highlights that were given in that guidelines to give them strength and emphasis. And that ends my presentation. I always like to acknowledge the Ministry of Health, especially the Division of Reproductive, Maternal, Newborn, Child, and Adolescent Health for their guidance on developing these policies and enabling the environment to thrive. My colleagues at URADCA, PSK for organizing this and also their collaboration. Of course, In Supply Health is our prime partner for their leadership. And more importantly, the partners who helped contribute to the development of the current guideline. So I'll stop there and hand over the session back to Hezron. Thank you.
All right, thank you, Dr. Isaac. I think that was a very insightful presentation. So I think we'll first of all start with reviewing some of the results from the pretest that we had. And maybe you can just confirm if you can see my screen. Are you able to see the results from the poll that we just had?
I can see myself.
Okay. So I think this is some of the feedback that we got. Maybe I can just read through some of the questions that we had and some of the feedback, and then I'll launch the post test, and then you can see the changes that we have. So the first question was on what's the primary mandate of the Kenya's National Family Planning Program, and 76% of you. The responses that we got, first of all, is 278 people who answered, and 76% said to ensure quality family planning services, capacity building, and technical assistance to the counties. The second question was on which new concept is being emphasized in the guidelines to improve the family planning services. And I think most of you got it right. Expanding contraceptive choices and promoting the male engagement. I think the other question was which of the following modern contraceptive methods is the most commonly used in Kenya? We had contraceptive pills as 60%. And the other question was on was a true and false question, which was the family planning guideline updates the medical eligibility criteria for the provision of contraceptive method and spells out task shifting.
Can you scroll,
91% of you.
Hezron, can you scroll down? I think it's stuck.
I think it's possible to scroll on your end. If you're able to just move it.
Okay, great.
Yeah, so on that question, I think 91% of you said it's true. The other one is Mandera recorded the lowest modern contraceptive prevalence rate. MCPR in Kenya at 2%, while Embu recorded the highest at 82%. 88% of you said it's true. The modern contraceptive prevalence rate in Kenya increased from 39% in 2008, 2009 to 57% in 2022. 91% of you said it's true. And then finally, what was the modern contraceptive prevalence rate in Kenya in 2022? And 70% of you said 7%. So we'll just be launching the post tests just to see what feedback we have based on this session that we just had. Meanwhile, I'd just like to encourage you to share your questions. I see we have 3 questions so far. So I think that we're going to handle that. And then we look at the results for the post test. So the first question is from Dr. Daisy, who's asking, from the table that you had shared, table 3.1, what's the difference between provide and dispense? So maybe we could start with addressing that.
Yeah, that's a very good question. Yeah, so so dispense is when somebody comes to your pharmacy with a prescription, and the prescription is written a certain product, and then you give them the product to go and take. That's what we call dispensing in my common language. But in family planning, providing is it's a technical term, actually. It's not like a verb. Uh, Providing is a method that requires more than just giving somebody a product. It requires you have to cancel, and if it's a procedure, then being able to undertake the procedure to provide that method. So and there is another term in family planning which is also technical, offer, which I think in this guideline the ministry avoided to use the word offering and stuck to providing, because providing was very clear what it was. So I think that's the difference. In providing, you have to do more than just dispense. You have to do more than just give a commodity. So that's the idea. And in the case of, say, injectables, it means that you have to prepare the client and be able to inject them, take the method. If it's psycho beats, it means you have to sit and cancel them and explain how to use the method. I know you also do that with some other commodities that you dispense, but I think the emphasis on providing is that it is more than just giving across the counter. Yeah. I hope that clarifies that.
Yeah, I think that's clear. So thanks for answering that. The next question is from Ziada, who's asking, are there any available tests carried out to determine sensitivity to copper IUD?
Yeah, I'm not aware of any, and I don't think that we do that because that could become a medical barrier. So what we do is when we counsel and a woman accepts a copper IUD, then we ask her to report back, call back, if she has any sensitivity experienced within 24 to 48 hours, so she can come back for review. And I'm not aware that this has been a major problem in our practice. So we actually, most people are safe with it. And then, of course, we have our mono IUD as an option now that can be provided for women who may have sensitivities or may fear having some sensitivity to copper IUD. So we have the mono IUD. But the straightforward answer is that we do not need to carry out any tests. But like with any other drugs or products, we always ask people to report back if they have any reactions or sensitivities. Back to you.
All right, thanks a lot, Dr. Next question is, how can we as pharmacists deal with cases of reproductive coercion?
Yeah, this is also a good question. Yeah, we are not supposed to do that. So so it's human rights. So that's why I emphasize. So the emphasis is that these services are supposed to address human rights, meaning that we are supposed to deliver in comprehensive information to the clients. We are supposed to enable them to make their own choice without any undue coercion. And then once they make their choice, then we are supposed to deliver comprehensive and detailed information on the method of their choice. So all this is actually in the, there is emphasized on the counseling methodology that you use. There is a balanced counseling strategy that the ministry uses in the training. So when you get trained, one of the training components is on the balanced counseling strategy to try and reduce coercion, because that is not allowable in our program.
Right. Thank you, Dr. for that feedback. The next question is from one of the members who's asking, what does the guideline say about providing a 12-year-old with FP coming to the facility for the service?
Yeah, so so the guideline, as I said, addressed some special groups, especially adolescents. And I think in our guidelines, Kenyan adolescents are from age 14 to 18, 14 to 18. So below 14 could be an area of a challenge. But adolescents between the ages of 14 and 18 are covered in the MEC will. So for the services that they can receive in that age group are covered in the MEC. So you should be able to counsel them and offer or refer those who need. And I think that addressing adolescents has been one of our challenges in Kenya as well as in other countries. And that's why the ministry started mainstreaming adolescent-friendly clinics, because some of our medical providers themselves were biased against adolescents. But I'm limiting myself very cautiously to the definition of an adolescent in Kenya from age 14 to 28. So anything below that may not be covered under the current policies. So you just have to be more careful about that.
Right. Thank you so much, Dr. We have two more questions that we can take up and then just quickly review the poll, because I'm seeing there are a couple of questions that are still unclear. So we have a question from Dr. Leah, who's asking, can a woman with hypercoagulation use hormonal IUCD?
Okay, I'm just checking my.
I think that's something that someone needs to go to the MEC also just
Yeah,
confirm.
but I'm just checking
Yeah.
it. Just give me a minute.
Okay.
Hormonal IUD. Okay. Okay. So hypercoagulation is, of course, excessive bleeding, so that can be an issue. So we should be cautious when using hormonal IUDs. However, some hormonal IUDs, like the one we have in Kenya, Mirena, they release progesterone and generally considered safe for women with clotting disorders. And in fact, they can even minimize some of this. In fact, the levonorgestrel IUD that we have in Kenya, one of the uses for it is for women who have bleeding disorders, either irregular periods or heavy bleeding. The hormonal IUDs can actually reduce it. But this would be, I think, in my view, would be a make 2/3. So you would have to track the woman closely so that you can know whether it's is doing what it is doing. So I think, yes, they can use, but they will require close monitoring, and it can actually reduce the bleeding, depending on what the cause of the excessive bleeding is. That would be my response for now.
All right. Thank you, Dr. Um, we have another question um, from Dr. Festus, who's asking, how is the uptake of vasectomy in Kenya?
Very low. And also people don't want to report on it. Very, very low. Yeah. So very bad. And I think it's starting with the medical people themselves are not even taking it up. So if we are not taking it up, obviously we are not going to convince other population groups to do it. But I also think other than just uptake, we have challenges of who is offering. So we have very few providers who are trained to safely provide vasectomy services. Men who would like this service would have to go to limited family planning clinics where the people have been trained and are provisioned to offer this. Even though it's a very safe and straightforward procedure, but obviously, we haven't been able to train enough people. And I think part of why the ministry and partners have not trained a lot of people is because maybe they haven't seen the uptake there. So you don't want to invest money training people if the uptake will be low. But it becomes like a chicken and egg thing. You know, when will you have uptake if you have not trained the providers? So I think it remains one of our challenges in the family planning program.
Right. Thank you, Dr. I think we'll take one more and then we look at the poll. So Dr. Shadrach is asking, can I give a fee without involving the other partner? And does the guideline say anything about it?
Yeah, so you can do that, but you have to talk to them. So when you talk to your client, you counsel your client. First of all, that counseling and taking your initial history, it will allow you to know whether what kind of relationship she is in, whether she is married, whether she is having a partner outside marriage, whatever her reproductive health status is or condition. And if she is willing to bring a partner for counseling, she can bring. But as far as she is an adult, she can give consent. There is no reason to deny her a method just because her partner is not there. So I would say a partner is an extra thing that you reach out to if the partner is interested in you reaching out to the partner. They actually have to bring their partner for counseling, but you should not deny people family planning services just because their partners are not on board. But obviously, there are some circumstances where the partner would tell you that maybe their spouse is against family planning methods or specific methods, and yet they would like to take. And maybe if they take, then they may have problems with their spouse at home, so that would cause a social harm. So you would have to address that upfront. So talking to your client, understanding his or her condition is important so that you can know what action to take. But the basic thing is that we should not deny family planning services to people just because their partners are not in the clinic.
All right. Thank you, Dr. So I think we'll quickly move on to the poll just to have a look at some of the feedback that we've gotten. And maybe you can just confirm if you can see the poll results.
I can see myself.
Okay, okay. So I think from the first question, I think there's been an improvement on the responses, and I think what I've identified is on question 3, on which of the following modern contraceptive methods is mostly common used in Kenya. Maybe you can give a clarification on that.
Yes, so according to the guideline, or no, according to the 2022 Kenyan Demographic and Health Survey, the commonest method is injectables at 20%, implants was at 19, contraceptive pills was at 8. Yeah.
Right, thanks for that. And I don't know if there's any particular reason for that. Maybe if it's something you could share, because I think it would be interesting to know why there's that shift, considering most people believe that contraceptive pills have been taken up the most.
Yeah, I think it's because of, actually, since implants were introduced in Kenya, I think the previous KDHS had placed implants at 14, and now they went up to 19, mainly because a lot of providers have been trained to offer implants. And also, the availability of implants has really been expanded across Kenya. So a lot of women who want a longer term method, 3 to 5 years, are able to access it. So that has been an issue. So a lot of women who are actually using pills or short-term methods started converting to implants so that they have a longer term method that they can use. So there we saw that shift from shorter term methods to longer term methods as we were bringing the implants. And then the same with injectables, especially the intramuscular as well as the subcutaneous. And more importantly, not just the availability of IM, but who is able to offer IM. You may be aware that trained community health promoters in hard-to-reach areas were trained and allowed to offer in injectable contraceptives, specifically the IM, starting in counties like Tharaka, Nithi County, where we did those demonstration studies, and also allowing pharmacists and pharmaceutical technologies to be able to offer injectable contraceptives. So again, this one has and expanded its use, as well as making the subcutaneous DMPA freely available in our sector, because we have had some donors who were able to reduce the cost, to subsidize the cost of DMPA in Kenya. So that has enabled DMPA AC to be introduced and to be scaled up. So these are some of the efforts that I believe has shifted the use from short-term to longer-term methods.
Right, thank you, Dr. I think that was the main question that I think that needed some clarification. But otherwise, I think there's been an improvement on the feedback that we've gotten. So I think due to time factor, we're just going to have the parting shots. And for members, I think I'll just want to remind you again that you ensure that you subscribe to this event on the PPB portal so that you get your CPD tokens on time. And for the parting shot, I'll start with Dr. Nyawira, who's also part of the OPC project, representing InSupply. She's just briefly going to say something. Dr. Nyawira, welcome.
Thank you so much, Dr. Hezron, for the introduction, and Dr. Malonza for the presentation. My name is Nyawira Wanjohi, a pharmacist and a PSK member. Today I join you as an analyst from InSupply Health. So maybe just a bit about InSupply Health. We are an advisory firm, East African health advisory firm. And our purpose is to enable communities to live healthy and happy lives. And how we do so is through our expertise in supply chain transformation, workforce development, data transformation, intelligence and impact, as well as market access and shaping. So for what you've heard today on market test and optimizing the pharmacy channel, together with PSK and other partners, including Pharmacy and Poisons Board, the Division of Reproductive, Maternal, Child, and Adolescent Health, we've worked closely to develop and execute those two projects. And market test, our goal was to develop and to test a viable and scalable pharmacy business model that could offer clients discreet and quality counseling as they provide contraceptive products. Here we focused on self-injection products such as DMPST and a larger basket of self-care products. And while we executed this, we saw the greater opportunity to strengthen the pharmacy channel so that we can increase the access for women and girls to an expanded and quality FP method choice, including implants. And through PSK, we have collaboratively engaged several members in training, mentorship, support, and project implementation. So thank you. And part of optimizing the pharmacy as a channel is to empower pharmacists with the up-to-date policies and regulations that support their delivery of quality services. And this is in line with PSK's mission to empower their members to promote professionalism and ethics. So thank you for your time. Before I hand over the virtual floor, I invite you to check out our website for further insight into the work we've done. You can also follow our social media handles at InSupply Health. We have various CPD accredited courses and micro modules that can help you advance your knowledge. Thank you so much. And back to you, Dr. Hezron.
All right, thank you a lot, Dr. Nyawira, and for the continuous support. So I think I'll also welcome Dr. Isaac Malonza, also give his parting shot.
Yeah, thank you very much, Hezron, for organizing this session and also your colleagues at PSK. I really want to thank all participants who had found time to join this session. I noticed we actually exceeded 850 at some point. So that's really exciting for me to know that we were able to reach many PSK members this evening. As I said earlier, it's a privilege and honor for me to have been provided with the opportunity to share this policy dissemination with all of you. We hope that we have had a chance to empower you. We will continue to work with the other partners on the OPC program to support you in the field, especially with by debunking or disseminating all these policies that the ministry has, and to be able to empower you so that you can be able to offer quality services out there. Uradica is also, together with InSupply, we are actually working with the Pharmacy and Poison Board as the PPB is working on a new program on improving good pharmacy practice, GPP. And together we are designing an assessment. So we'll be coming to your facilities sometime soon to just hear from you how the pharmacy practice, the current status of pharmacy practice. So again, it's a privilege as Uradica to be partnering with PSK, InSupply Health, and Pharmacy and Poison Board to work with you all to ensure that we can strengthen ourselves and be able to offer quality services in our facilities. So I wish you all the best. Stay tuned, and we invite you to join future sessions of this nature. Asante sana, and back to you, Hezron.
All right, thank you so much, Dr. Isaac, for that presentation, and we really look forward to having you in the future sessions that we'll be having. So I'd like to also welcome Dr. Joe Kamau. Dr. Joe, if you can hear me.
Loud and clear, Hezron. Thank you for organizing this webinar. Mine is to congratulate all of us who have joined. 278 is a number that we didn't think that would join us. Thank you very much for this.
It's 850 actually.
850. Okay.
Yes,
okay, I'm sorry. Yeah, so I want to congratulate everyone and to say thank you for joining. I will be participating in and we hope that every time we call on this policy review, policy dissemination meetings, we'll have even a bigger number. Mine is to engage you on the short videos and to look at the InSupply website to enrich yourselves with the skill because again, remember optimizing the pharmacy channel, you might find that a big word, but it's simply we are trying to engage our community pharmacies to offer short-term methods and to reduce the burden at the public health facilities. So when you have that in mind, then you have a feel or an understanding of what the OPC project is all about. Mine is to thank you all and to say good night, alamsiki, asante.
All right, thank you so much, Dr. Joe. For those who are not aware, Dr. Joe is the technical lead for the OPC project from the PSK office. So at this point, I'd like to just send a reminder for a couple of activities that are coming up. We have a webinar that this is organized by FIP, and we'll be sending reminders on the WhatsApp platforms so that you can also just take part in this session. The title will be 3D drug printing, revolutionizing drug fabrication. This weekend we have on 1st of February, which is on a Saturday, we'll be having a mentorship walk that will be happening, and you are very much welcome to come and interact with other pharmacists, learn from each other, and also get to mentor the younger pharmacists. Then finally, just a reminder for those delegates of the conference who missed last year, if you didn't get your bag, you are encouraged to come to PSK and pick your items. So at this point, I'd like to close the session and remind you again that ensure that you subscribe to the event on the PPB portal so that we can send the CPDs on time. Once again, thank you, Dr. Isaac Malonza, for the support and for sharing those insights. We're looking forward to having you again. Dr. Nyawira and Johi, thanks a lot. And Dr. Joe, thank you. And for all members who joined us today, thanks a lot and have a good night.
Good night. Thank you.
Good night. Meeting adjourned. Thank you very much.